The health and medical information provided during this webinar, as well as the questions and responses from the webinar providers, are solely for informational purposes. This content is not intended to take the place of advice or treatment from health professionals. Nothing presented in the webinar is intended to be used for medical evaluation, diagnosis, or treatment. It is not intended to substitute for your relationships with your own healthcare and pharmaceutical providers. Always seek the advice of your healthcare provider before beginning any new treatment, or if you have questions regarding a medical condition.
So we're going to talk a little bit about incontinence tonight. Believe it or not, it's actually a fairly common problem that men can experience as they age and the years go by. So to begin, a quick review over the normal urinary function that happens in men. The kidneys make urine, and that trickles down through the ureters. There are two tubes that carry the urine from each kidney down to the bladder. And then the bladder stores urine and basically fills up over time. The muscles of the bladder relax to hold that urine. And then once you hit a point where you're full and it's socially appropriate, you can go into the bathroom and you trigger a reflex where the bladder squeezes. The urethral sphincter muscle opens to let the urine out the urethra. And then when you're done, that sphincter muscle closes up, the bladder goes back to relaxing and holding urine. So that's normal urinary function, and a lot of different things go into that, nerves and muscles and different coordination and reflexes in the body. And incontinence can happen when some of those reflexes or some of those structures don't work the right way. So we'll get a little bit more into that. So we'll break this down into three big topics: what incontinence is, what causes it, and how common it is. So the types of incontinence that happen really can be broken up into a few categories. The first one of these is stress incontinence. And this is incontinence that happens with any kind of increased pressure on the bladder. It usually happens because the sphincter muscle doesn't close or squeeze as tightly as it used to, so that urine can come out through that open sphincter. Leakage can happen during times where straining occurs, like lifting something heavy, or if the belly squeezes during a sneeze or a cough or laughing. All those things put pressure on the bladder, and then they make the urine leak out through the sphincter and through the urethra. It's very similar to what women can experience after childbirth, and it's probably more discussed in women and potentially more common. But it's definitely a problem that men can experience for one reason or another. Urge incontinence is another very common type of leakage that happens, and in large part that's driven by a lot of things that we come across in our day-to-day lives. So things that irritate the bladder and cause that muscle to spasm and squeeze and force urine out are really the big drivers of urge incontinence. There's 5 major things that irritate the bladder that I tell my patients to try and avoid to reduce urge incontinence. And those are caffeine, alcohol, sweeteners, flavorings, and colorings. So a lot of things that are in normal everyday fluids that people consume. Caffeine being a big one in coffee and soda, sports drinks, power drinks, energy drinks, teas, juices, things like that. They may have sweeteners and flavorings and colorings in them. And then obviously alcohol and cocktails and beers and wine. All those different things can make urge incontinence more likely to happen because they irritate the bladder and they make that muscle very spastic, and it wants to unload and get rid of the fluid that's in there. Overflow incontinence is a different kind of incontinence, and that's more related to a backup or blockage of urine flow in the system. And that could be from an enlarged prostate. It can also be from a dysfunction in the sphincter that makes it stay closed, which can happen in some neurological conditions. Scarring in the urethra or blockage of the urine tube that carries urine out is another reason that can happen. And what happens with overflow incontinence is, just as the name says, the bladder fills up and fills up and fills up, and then the urine spills out because it can't hold anymore. It physically hits its capacity, and that's what causes the urine then to leak out through the urethra. Neurogenic incontinence is a little bit less clear. It can happen for a number of reasons. So with neurological conditions, you can lose the coordination of the bladder and the sphincter muscle. In normal urine storage, the bladder muscle relaxes and it fills up and it holds urine at a low pressure, while the sphincter muscle closes down to hold that urine inside. With some neurologic conditions, you can lose that coordination, and that bladder muscle may fill up and then spasm or cause leakage, almost like urge incontinence. And the sphincter muscle may or may not open or close in coordination with that. So things like Parkinson's disease, multiple sclerosis, those type of conditions, spinal cord injuries, any type of neurological conditions where there's degeneration or a loss of function of nerves, or even ones with muscle spasticity, can all cause incontinence related to that neurogenic etiology or that neurogenic reason. So how common is urinary incontinence? About 3 to 10% of men will have moderate to severe incontinence during their life. And I can tell you that many, many, many more men than that will have mild leakage at some point in their lives. It's very common as we age that our bladders become more impatient and also more irritable. And it makes sometimes for difficulty getting to the bathroom quick enough. So men can have urgency incontinence because they don't get to a toilet as fast as they need. And that happens as age comes. It happens as the years go by because, again, that bladder really becomes more unstable. Incontinence, though, is not something that you should expect to have with age. It's not something that should be considered a normal part of aging. You know, a lot of incontinence is a result of changes that happen in the body and then things that we do that can cause the leakage. So drinking too much coffee, drinking too much pop, treatment for cancer that can make the sphincter muscle weakened, or radiation that can make the bladder muscle even more irritable. So if you look at those different things and how they kind of pan out in the population, what you'll find is that the vast majority of incontinence that men have is actually urge incontinence. It's that impatient or irritable bladder. Less common than that is stress incontinence. And that's only about 10% of cases, and usually that's in the setting where somebody has had some kind of surgery or injury or a neurological condition that causes that sphincter muscle to not work properly. Then there's a big overlap between the two where you have mixed incontinence. And mixed incontinence is when you have both stress and urge overlapping at the same time. And it's an important thing to recognize because the treatments for stress incontinence are very different than the treatments for urge incontinence, and they generally don't help one another. So you can do the right treatment for stress incontinence, but if somebody has urge incontinence, it'll generally continue to still be a problem. So let's talk a little bit more about stress incontinence and how that relates to prostate cancer treatment. So prostate cancer treatment is generally done with a few different approaches. Management-wise, active surveillance or monitoring prostate cancer is one option, but treating prostate cancer is done usually with surgery or with radiation treatment. And that's based upon the national guidelines that we have from the National Comprehensive Cancer Network, as well as a number of other professional organizations. So in radical prostatectomy, the prostate is actually removed completely. And you can see in the figure here, the prostate sits between the urethra and the bladder. When you take that prostate out, you then sew the urethra and the bladder back together. What can happen sometimes is that by pulling on the prostate, trying to get it out, and based on a man's anatomy, that sphincter muscle may be right up against the prostate, so that when the prostate is removed and you sew things back together, it can pull on the sphincter muscle. Sometimes the nerves that go to the sphincter muscle can be irritated by surgery, and a number of different things can happen. There's a lot of different theories as to why leakage may happen with prostate removal. But what we know is that in men that have leakage after prostatectomy or prostate removal, it tends to happen because that sphincter muscle is not closing tight enough. Radiation tends to be another cause of leakage that guys have, and that also can cause the sphincter muscle to not squeeze as well. Radiation tends to affect it in a different way, though. It can cause the nerves that control the sphincter muscle to not function as well. So maybe that signal isn't there to the nerves, but also radiation can make that sphincter muscle very stiff. Radiation changes how tissues heal from injury. It also changes how tissues are. It can make almost like a scar form and tissues to become more stiff or more rigid. So that's how radiation itself can cause leakage. In some cases of prostate cancer treatment, you actually will have radiation after surgery, or the other way around. Men that undergo radiation, they have cancer come back, and then they pursue removal of the prostate. In situations where you have surgery and radiation, whichever the order, your leakage tends to be more likely to occur, and it can be more severe. So looking at everything, most men after prostate surgery will leak urine for a few months. It's very normal. And over the healing process, usually the first few months after surgery, a lot of that urinary control comes back. However, there's a percentage of men, and depending on the study you read, it could be anywhere from maybe 10 to 15%, who have permanent lifelong leakage after prostate cancer treatment. And that's where we have surgical options and other treatments that we can do to help address leakage. So getting a little bit more into what some of those treatments are, we'll go through some options here. The basics for incontinence treatment, and a lot of this is based off of what I do in my clinic, is really to start with the simple things and go from least invasive to more invasive as needed. So behavioral strategies are the number one thing I start with any incontinence patient. And that can be whether it's urge incontinence, which is that most common type from bladder irritation, or stress incontinence, which is when that sphincter muscle doesn't close well. And then again, those cases where they overlap. So for urge incontinence, behavioral changes and dietary changes are the main recommendation. Those include making sure you go to the bathroom often enough. So believe it or not, we should actually pee every 2 to 3 hours. However, in society, we're taught at a young age that we need to hold our urine, right? Think back to elementary school. You put your hand up, ask the teacher to go to the bathroom, and they come by and say, no, it's not time for a break, finish your assignment. Then you get into your working years, and you tend to have jobs where maybe you only have breaks at certain intervals, or you just have a lot of work you're trying to get done and you put off going to the bathroom so you can finish it. But we really should pee every 2 to 3 hours. So that's kind of step one for behavioral changes. Step two is to avoid those things that irritate your bladder. So again, caffeine, alcohol, sweeteners, flavorings, and colorings. Those 5 things. Safe things to drink are good, plain, old-fashioned water. And if you need to have flavor in that, put a slice of lemon or a slice of lime in it. Stay away from the flavoring additives, the little packets and things that you can squirt in, because again, what's inside of those? Sweetener, flavoring, and coloring. All things that can irritate the bladder and make urge incontinence worse. Plain milk is also generally well tolerated and doesn't seem to bother the bladder much as well. However, we know that not everybody can drink milk. Some folks are lactose intolerant. Other behavioral strategies include pelvic floor exercises and physical therapy. So physical therapy is a way that you can learn to help coordinate and control the pelvic muscles better. And there's reflexes in there that can actually help the bladder relax and hold urine better. So specialized pelvic floor physical therapy is another approach that we use a lot in our practices to help men with incontinence. Beyond that, the other behavioral strategies that we have are all related to different hygiene products and devices that patients can use themselves. So in folks that have leakage, absorbent pads inside the underwear are one strategy. Bigger pull-up undergarments, almost like diapers, are another strategy. And those are things that you have to change throughout the day. They can get wet. It can become kind of heavy and sometimes carry an odor. There's also a number of other products, and those can be leak-proof underwear that you can wear on top with a pad inside, or just different ones that have absorbent material built into them. You can take them off and wash them. There's also clamps or external devices that you can apply on the penis to kind of compress it a little bit to reduce the flow of urine and prevent leakage through that. And then there's also external catheters and all kinds of collection devices that folks can put inside their underwear to try to catch the urine that leaks out and divert it. Beyond the behavioral strategies, the next step is really to consider medical therapy. And this is for urge incontinence. Medical therapy in the United States is not used for stress incontinence. There's no medications that are FDA approved to be used to treat that. So the medications that focus on urge incontinence largely focus on relaxing the bladder. And those are medications like beta-3 adrenergic agonists. Those would be mirabegron and vibegron. And then PDE5 inhibitors. Those would be medications like tadalafil, which is a very low dose daily pill that somebody can take. Relaxes the bladder a little bit, and it also actually relaxes the prostate too. So it makes men with prostate enlargement urinate a little more easily. Anticholinergics are another medicine that relax the bladder and help it store urine. The downsides to those, though, they're a little bit older. They can cause some dry mouth, dry eyes, and constipation. BPH medications are another way that incontinence can be treated. And thinking back to that other slide, these are really targeted towards overflow incontinence. So men who don't empty their bladder well, who are overflowing and backing up with urine, those BPH medications can relax or shrink the prostate to open it up so that guys can pee better and they can empty and then not overflow. Beyond that, surgical procedures are really the next step in terms of treating incontinence. So male slings are one option to do that. Those are a little hammock that go in and they kind of push up and rotate the urethra. They elongate the continence zone, or they kind of reposition the urethra to allow that sphincter muscle to squeeze a little bit better. The artificial urinary sphincter is another surgical treatment for incontinence that's been around over 50 years now, believe it or not. And it's almost like a blood pressure cuff, except it's a little cuff that goes around the urethra, and when it's in there, it's closed all the time, and then there's a little pump that goes next to the testicle and the scrotum. You squeeze and it opens up. So it's a mechanical device that goes in and does a very nice job of reducing leakage. Botox injections and neuromodulation are surgical treatments not for stress incontinence, but for urge incontinence. And those are ones where you go in and you're, again, trying to get that bladder muscle to relax and store urine at a low pressure and hold better. So the behavioral modifications, I touched a little bit on these on the last slide, but it's really good to review these and get familiar with them because they do have a major impact and a major benefit for a lot of patients. So the bladder diet, certain things you'll read, especially on the internet, will say, you need to do this, need to do that, avoid this, avoid that for your bladder. One of the easiest strategies I give my patients is if you're thirsty for something, plain water or milk. Try it even just for a few days. Give it 3 days of limiting your fluids to water or milk if you drink something. And you'll pretty much see that the bladder calms down. You have to rush to the bathroom less often. You're able to hold your urine better. The specific things that cause it, again, caffeine is a big one. So coffee and tea, energy drinks, pop or soda. Alcohol intake is another one. And then artificial sweeteners and colorings are the last. And those are kind of hard to avoid nowadays, believe it or not. Sports drinks, a lot of juices, teas, and things like that will actually have artificial sweeteners and flavorings and colorings in them. Constipation is another underestimated, factor for urge incontinence. Your pelvis is only so big, and the bowel is in the back, and the bladder is in the front. So what can happen is your constipation can actually fill the bowel up and compress the bladder and make it harder to hold your urine. So the way that you navigate that is really to make sure you're bringing in enough water to keep the stool soft and kind of keep things moving. Bladder training is kind of a lay term for timed voiding or making sure you pee every 2 to 3 hours. Also, strategies for that, you want to make sure you drink enough water to keep your urine clear, light yellow. That makes sure that it doesn't get too concentrated. If urine gets really dark, it's basically really strong, salty acid that's sitting in your bladder. Your bladder doesn't really like that either. And then physical therapy, again, for bladder training, that's kind of a very important thing. Pelvic floor physical therapy is done by very specialized physical therapists, and it comes in strengthening and then relaxation, kind of two big categories. The strengthening is what we use for stress incontinence or that incontinence from weak sphincter. And then relaxation is what we really focus on in urge incontinence, trying to get the bladder to relax and hold urine better. Those pelvic floor muscle exercises, again, are really targeted towards strengthening or relaxation. And those pelvic floor exercises really are things that are best learned with a physical therapist. You can actually worsen your symptoms if you do the wrong kind of exercises, even though they may be pelvic floor exercises. So that's really something to do and learn under supervision. Then once you get that skill set, they're easy things that you can do at home. So in terms of some of the products and things that patients can use at home to help with continence, pads obviously are one. They catch urine. I also mentioned that there's some larger ones, briefs or pull-ups, almost like a diaper, that can be worn as well. But the downside here, obviously, they get kind of heavy. Sometimes you can feel damp, and then sometimes they can have an odor, and make patients feel like they smell like urine. Leak-proof underwear are another strategy, and those basically are waterproof garments. Some of them have absorbent elements built into them. They're reusable, and they can do a nice job of sort of containing, leaked urine and masking odors that happen. Penile clamps are something that have been around for quite a long time. There's different names associated with these, but they all work in pretty much the same fashion, where there's a clamp and then some kind of padding, and then you basically put the penis inside, and what they do is they squeeze down and they pinch off the urethra to reduce leakage. The important thing with those is that during the day you move them around, and you never ever wear them to bed at night. If you leave one of those on too long, you can actually cause permanent damage to the penis. Catheters are really kind of the last stop, for a lot of urologists. External catheters or condom catheters are one strategy you can use. You wear a little bag under your pants during the day, and then you can put a big bag on at nighttime and hang it off the side of your bed. There's all kinds of other different external collection devices that are on the market as well. So getting a little bit more into the medications now, kind of moving out of that first line treatment into that middle column on that one slide we looked at. Overactive bladder medications, they all have the main goal of trying to relax the bladder muscle so that it can hold urine at a low pressure and reduce leakage or reduce the number of trips people have to make to the bathroom. Beta-3 agonists, mirabegron being one of those medications, are really the best class of medication for this. They're very safe, they're very effective, and they have very, very few side effects in interactions with other medications. They don't carry risks like dementia and confusion that some of the older medications do. They're relatively new to the market, but they've been around long enough to been studied and really been found to be safe and effective. Getting to the BPH medications, the way that those work for leakage, again, is to help the bladder empty better. So in men who have overflow incontinence from prostate enlargement, these medications can relax the prostate to help the urine come out more easily. Tadalafil, which was originally used to help with erections, was found at a very low dose each day, 5 milligrams, to actually have a very nice relaxing effect on the prostate, as well as a little bit of a relaxing effect on the bladder. So I like to use this medication in men who have a combination of prostate enlargement and some overactive bladder. You can tend to see a benefit in each of those two areas. That medicine is very well tolerated at the 5 milligram low daily dose. The side effects that come with the higher doses that men may use to help their erections really aren't there. Those side effects, though, facial flushing, nasal congestion, headache, heartburn, things like that, you really tend to just see those at high doses of tadalafil that men use to help with activities in the bedroom. Tamsulosin is an alpha blocker. This has been around for a very, very long time, and it's a lot of urologists' first stop for prostate enlargement to help men pee better. This and tadalafil, the medication above, both will take effect in about 3 days or so. This medication relaxes the muscles in the bladder neck and the prostate to help the urine come out more easily. The bladder neck is just the junction where the bladder and the prostate meet up. The downside, though, to tamsulosin is it can also relax the muscles in the blood vessels a little bit. So if you stand up or get up too quickly, you may feel lightheaded or dizzy. That tends not to be noticeable with tadalafil because it works on a different receptor in a different way in the body. So the surgical treatment for incontinence, really there were a few of those that we talked about. Neuromodulation and Botox are for urgency incontinence and overactive bladder. We'll kind of leave those aside and not really focus on those much tonight. But one of the ones we want to talk about are, the treatments that are for stress incontinence. And that, again, it's that incontinence that becomes present because the sphincter muscle doesn't close very well. So the male sling is one treatment for stress incontinence that's been around for quite a long time. Actually, when I was in my residency training, it was relatively new back then, and we did one of the early research studies on it to figure out how patients did after treatment and how the results held up over time. So for mild to moderate stress incontinence, the sling is a very nice procedure. It's an in and out same day surgery. It's completely inside the body, and there's not really anything noticeably different about the body after the sling goes in. For mild to moderate leakage, that's usually what we consider to be 1 or 2, maybe 3 pads a day of leakage. That 3 pads a day, if you're out at that range, hopefully they're not overly saturated, they're just kind of damp. But for that mild to moderate leakage, you can really see good results with the sling. The cool thing with the sling is that the benefit, it happens immediately. And the new generation of these slings, the Advanced XP, which you see on the slide here, they tend to tighten the urethra very, very nicely, almost too tight. So some men, when they have these put in, they won't be able to urinate for the first day or two because of swelling from surgery, and also because the anesthesia from surgery can make their bladder a little bit lazy. So you go home usually with a catheter for a day or so after these procedures, but they do a really nice job of helping reduce leakage. And again, the way they work is that hammock kind of pushes in and it rotates the urethra up and in a little bit to take stress off of the sphincter so that muscle can close better. So the male sling, a little bit more on that in terms of results, and treating leakage and treating incontinence. Our patient-reported results are really the most important things for us. Yes, we can reduce the number of pads somebody uses every day, and that's an easy thing to measure. But the most important outcome in treating incontinence and quality of life problems is patient satisfaction. And ways to measure that are through asking patients, would you do it again, and would you recommend a friend or family member? And if you look at that data for the urethral sling, over 90% of patients said they would undergo the sling procedure again. And 94% of them would recommend that procedure to a friend if they were having the same problem. So you can see the satisfaction with these is pretty high. They're very nice, procedures, they're very nice devices. And again, for the right patient, they do a great job at helping reduce leakage and incontinence. As mentioned on that first slide, recovery is pretty straightforward. You have a catheter for about a night or so. You may be sore down there for a week or two after surgery. Like any surgery, there's some risks associated to it. Failure of the sling or movement of the sling, not really one that I'm worried about. Usually that happens because somebody gets back to doing vigorous activity too soon after surgery. So if you take it easy for a little while afterwards, it's very unlikely that you would have that problem. Urinary retention, being unable to pee, that's actually a good thing. And that means that sling has really tightened things up. But that's also why with the new generation of sling, we leave that catheter in, for a day or two after surgery to help wait till the bladder wakes up from anesthesia. Pain and discomfort with any surgery, a little bit of, soreness is normal and to be expected. Inflammation or foreign body response, irritation at the sling site, that's very, very rare, but it's something that with any implant in the body, you kind of consider. And then lastly, anytime you do surgery, bleeding, infection, and injury to things is always a risk. But in an experienced surgeon's hands, those are all very low potential, for occurring, and really things that we don't worry much about. The artificial urinary sphincter is another way to treat incontinence, and this is great for incontinence that's more substantial. The artificial sphincter has been around for over 50 years, and as mentioned, it's that cuff that goes in, it closes around the urethra, and then you can see there the control pump that's under the skin, just right next to the testicle, and then the lower half of that where the arrow points is the part that you squeeze to open that valve up, open up the cuff, so that you can pass urine. The devices are pretty cool. When you pump them open, they stay open for about 30 seconds or so, and then they gradually close back down. So once you open it, you can pee, and then it automatically closes back up. You take your time at the toilet, and then you can turn around and go. These devices, much like the sling, are also very discreet. They're completely within the body. And the way that these work, they really mimic the function of a healthy sphincter. And as mentioned, you can use this in more severe incontinence, and it also works fine for mild incontinence. So you can really use it for anybody who has any degree of stress incontinence. This is a little video. It shows how the artificial urinary sphincter works. And what you'll see here, it's just an animation of a body. It's kind of translucent. You'll be able to see the implant inside there. So as you zoom in here, you can see the cuff on the urethra there towards the back. You can see the pump kind of right in front of us in the scrotum. So the patient's going to pump that pump, and then if you look in the corner up there, the cuff opens up and the urine flows out. And then what will happen is over time, that fluid automatically goes back in and that cuff tightens up again. So very nice kind of simple system to help open and close the urethra to allow urine to flow or to hold it back and keep it from leaking. So after the artificial sphincter surgery, recovery is also very straightforward. Like the male sling surgery, this is an in and out same-day surgery. It doesn't require an overnight stay in a hospital. There's a little cut down behind the scrotum underneath called the perineum. There's also a cut there for the sling. And then a little cut on the belly where you drop a reservoir in that holds the fluid underneath the belly muscle. There's obviously with surgery a little bit of bruising and some swelling, and that's fairly common. And then much like the sling, you have to take it easy for a little while after surgery. You want to make sure everything heals in place and heals appropriately. The difference between the sphincter and the sling, though, is the sphincter has to heal in place for a little while before it can be activated to be used. In our practice, we usually wait about 6 weeks before having a patient come back and have that device activated and then start to teach them how to use it. So looking at the results for the artificial sphincter, you can see on the slide here, also this device provides a very, very high satisfaction rate in terms of patients being happy with their outcomes. About 95% said they're satisfied with their device. 90% are happy with their device over the long term, and that's it over 10 years when asking that question. So really long-term data there. 90% of patients would have surgery again, and 94% would recommend it to a family member or friend if they were having the same problem. So, again, these devices, they've been around for over 50 years. They do a very nice job in terms of helping men control leakage and regain some of the confidence, that they've lost because of that. In terms of the device and, risks, again, like any surgery, there's some risks. With implanting a mechanical device or a hydraulic device like the artificial sphincter, there's at some point, the risk for mechanical failure. These are very robust devices. They last a very long time. We tell our patients to expect, 7 to 10 years out of them easily. But obviously they can wear out from being pumped and being squeezed and manipulated. If that happens, you go in, you take out the broken system, you put a new system in. It's pretty straightforward. Erosion of the cuff, where it squeezes the urethra, it can kind of wear into the tissues. That's pretty rare. It doesn't happen very often. What can happen, though, is if a patient is unconscious and somebody places a catheter through the urethra and through that cuff, that can cause urethral damage and cause erosion of the cuff. So that's one thing we counsel all of our patients about with the artificial sphincters, is to make sure that you either have a medical alert bracelet or something that tells people you have an artificial sphincter, so that they don't put a catheter in you without you or a urologist first opening up and turning that device off. So that's really a kind of a unique caveat to the artificial sphincter device. Urinary retention is a very low risk with these. If the device can't be used, if a patient can't use their fingers, something happens, they fall ill and they can't open and close the device, generally the bladder can fill up and fill up and fill up, and then it'll overcome the pressure there, and the bladder will empty a little bit of urine to keep things safe. And again, with any kind of surgery, infection, pain, and soreness are always risks, but in an experienced surgeon's hands, those are very, very low risks. In terms of cost and coverage, this varies a lot in terms of private insurance or commercial insurance in the United States. However, Coverage on Medicare is actually pretty robust. So for folks who have retired or who have shifted over to Medicare, there's actually good coverage in place for this, which is nice because, again, we tend to see urinary incontinence happen more in men as they age, as the years go by. The same with prostate cancer. It tends to be a disease of men as they age, and with leakage related to some prostate cancer treatments. Again, that may be something that's more relevant to a Medicare population. Otherwise, if this is a condition that you struggle with, that you have to deal with, and you're working with a healthcare provider to treat your incontinence, don't hesitate to ask them. There's different avenues and different ways that your healthcare teams can help you advocate for treatment. There's also some support through other avenues where other resources can be brought in to help you find care and get the care you need. All right. So to wrap up here, this really covers the surgical treatments for stress urinary incontinence. The sling and the sphincter, again, they've both been around a long time. They've withstood the test of time. The satisfaction rates and the data you saw there kind of speak for themselves. Both are very effective at helping men reduce incontinence and enabling men to get back to urinating when they want and where they want. The devices are both very discreet. They're inside of the body. And treating incontinence is a big deal. It really detracts from people's quality of life. Confidence, men feel much more confident when they're able to get their leakage controlled. And a common phrase that you'll hear patients say when they come in to see you after treatment is, "Thank you for giving me my life back," right? It may have been the cancer treatment that saved their life, but dealing with incontinence, dealing with problems like that can be socially isolating and lead people to really avoid doing the things that they enjoy. So if you're able to help someone with incontinence, you tend to see a really happy patient there, and they really do feel like they've gotten their life back. For more information on those surgical treatments, fixincontinence.com is a very nice website. It covers both the sphincter and the sling. It's a reference I commonly send my patients to look at.
Sounds good. So I would just like to thank Boston Scientific for making this possible tonight. They're the makers of the surgical treatment options that Dr. Gill just spoke about. So first group of questions is going to be about general urinary incontinence, some of which may be a review. So bear with us as we cover some pretty important stuff once again. So first question today is, most elderly people believe that incontinence is a part of growing old. Is this true? And I guess what percentage or how often are people diagnosed with incontinence?
Those are both great questions. So, incontinence is not a normal part of aging. The normal part of aging is having a bladder that is more irritable and more impatient. So, just as you have to pay more attention to maintaining balance and, keeping steady on your feet as you age, you also have to pay more attention to taking care of your bladder. So, strategies to reduce incontinence and really avoid those type of things are to make sure you pee every 2 to 3 hours and that you avoid constipation and you try to keep away from bladder irritants. So to recap those 5 things: caffeine, alcohol, sweeteners, flavorings, and colorings. Obviously, with some conditions like prostate cancer, that is more common as men age. So prostate cancer treatment is more common in older men than it is in younger men. So the surgical treatments for incontinence, the sphincter and the sling, we do tend to see those needed more often as patients age. In terms of the rates of incontinence, that's a very good question. Those vary across the studies that you read. If you go back to some of the slides that we looked at earlier, urge incontinence by far, that's that irritable bladder, is the most common type of leakage that we see in our office. Stress incontinence is far less common. Part of that is because we have gotten a lot better at doing prostate cancer surgeries nowadays. The robotic approach has helped with that. And that makes up the minority of the incontinence cases that we see. If you ask me, I would say, most men, so I would say, over 50% of men in their 60s, 70s, and 80s experience some degree of incontinence. And, that may just be a little dribble or a little bit of leakage trying to get to a toilet or rush to a toilet in time. And again, that plays back into that bladder becoming more impatient and more irritable with age.
Alrighty, awesome. Next question here. So what is the difference between terminal dribbling and post-micturition dribbling, if I pronounced that correctly?
That's a great question. Somebody used the official medical terminology there, so kudos to whoever submitted that question. Post-void dribbling or post-micturition dribbling is dribbling that you get after you're done peeing. So when you walk away from the toilet. And what I liken that to is, when you go out to a restaurant and you see a little kid playing with a straw in their water, right? They put their finger on top of the straw, they take it out of the cup, they take their finger off, and then the water all falls out of the straw. The same thing happens with the prostate and the bladder and the urethra in men. So you can urinate and your pelvic floor muscles can still be a little closed. And then when you turn to walk away from the toilet, you start to walk and those pelvic floor muscles open up. That's your finger coming off of the straw, and that's what makes that urine come out. So what I usually recommend folks do is they pee and then they wait a second and they just take a small step forward and then a small step to the side. Take 2 little steps at the toilet bowl and then give one more shake and get the last bit of that urine out. And what that tends to do is it relaxes those pelvic floor muscles, opens them up, lets that last little dribble out so that it doesn't come out when you're turning and walking away from the toilet. Terminal dribbling is a little bit different. Terminal dribbling is a result of the stream slowing down once the bladder becomes more empty. So everybody pees slowly at first, and then as the bladder really squeezes, they pee fast, and then as the bladder empties out, they pee slowly again. So that little kind of bell curve with how fast you pee is normal for everybody. When that curve slows down towards the end of urination, there may not be enough pressure to open the urethra fully, and it can cause the urine to spray or dribble around. There's not really a good solution for that one. I would say just make sure your aim is good and you're pointed in the right direction.
Next question here. So this person says, please share advice for treating post-void dribble. I've had this since my late teens with no UTI or STD history. I'm currently 35.
Yeah, so it goes back to what I had mentioned there, in terms of the pelvic floor. So, if it's something that's been kind of a lifelong challenge, taking a little bit more time in the bathroom, making sure that you stand there till you're empty, you try to relax everything, and then taking those little steps at the toilet bowl, a step forward, a step to the side before you kind of shake and walk away. That can be helpful. Physical therapy, pelvic floor physical therapy to focus on relaxation and coordination of the pelvic floor muscles also can be of some benefit. Some folks have tried medication like tamsulosin to see if that helps. There's kind of mixed results on that one. But the downside, tamsulosin in someone who's in their 30s is also going to weaken ejaculation. So something to keep in the back of your mind. If somebody's looking to start a family or anything, tamsulosin can reduce ejaculation and may cause some potential challenges for fertility while you're taking it. But not long term. If you stop taking it, that comes right back to normal.
Certainly. Okay, next question here. Can urinary incontinence also affect erectile dysfunction or climax?
Great question. So not directly. Both conditions happen in the same organ in the body. We know that. But usually what you see is that in men who have incontinence, there's an element of self-consciousness there. There may be, a reduction in confidence, right? They may be worried about leakage. They may be concerned that, hey, they could leak when they're trying to engage with a partner. Things that really can put a hamper on sexual activity. And so, on those ends, doing things to treat incontinence and improve incontinence can help restore confidence in men and help them feel more comfortable about engaging with their partners. So that is one way that those, conditions overlap. Obviously, in men who have had cancer surgery, pelvic surgery, radiation, things like that, those conditions can happen simultaneously as well, because the nerves or the muscle in the sphincter can be impacted, and then the nerves that cause erections can be impacted from surgery or radiation. So that's another way that those things can be related, but generally not, a cause of one another.
Alrighty, moving right along. Next question here. How long should someone try non-surgical methods such as pelvic floor exercises or medications before considering one of the surgeries we covered tonight?
That's a very good question. So the best evidence we have, the best kind of guidance we have on that comes from what we know about prostate cancer and prostate, prostatectomy or prostate removal for cancer. We generally see urinary function start to recover the first maybe 3 months after prostate cancer surgery. And then from 3 months to 6 months, you see continued improvement and things start to level out. And then from 6 months out to a year, you may see some minor improvements in leakage. So, that being said, if you're in that first few months, really give it some time. Make sure you're doing your exercises. Kegel exercises are often discussed in those situations. But if you're 6 months out and there's really profound leakage, many pads a day, or just, complete lack of control, the potential for recovery at that point, over the next 6 months out to a year, is probably not going to be, really substantial. And then obviously, if you're a year out from prostate surgery and you're still having, fairly, remarkable incontinence, then at that point, considering, a surgical intervention is very reasonable. That first, 1 to 3 months, definitely not. Give things time to recover. From 3 to 6 months, usually the recommendation is to kind of wait and see as well. But by that 6-month point, you generally have a gut feeling for, how a guy is going to recover and how much control, may or may not be coming back.
All right. Next question here. How does one decide between the sling and the AUS?
Very good question. So there's really a few things that I talk about with patients when they're evaluating those options. The most important really is the amount of leakage that they have. So for mild to moderate incontinence, maybe 1, 2, 3 pads a day, the sling is a great option. You can also do an artificial sphincter for that mild incontinence. It'll have benefit there as well. However, for more severe incontinence, 3 or more pads a day, 3 really wet pads a day, or 4, 5, 6 pads a day, the artificial sphincter really is the best way to go. You can do a sling procedure in men that have more leakage. However, the benefit that it provides is not going to be as substantial as what an artificial sphincter can provide. So that's really a big recommendation that I make, is that amount of leakage. Other things to consider are other factors about the patient. So does the patient have good hand function? Are they able to reach down and, would they be able to find under the skin on the scrotum where that pump is to be able to pump it? If someone's had a stroke and they don't have good hand function, things like that, then the artificial sphincter may not be the right option for them, because they won't be able to open it to empty the bladder and function it appropriately. So that's another thing that we think about. Other things, prior surgeries in that area, radiation, things like that, those all come into play in terms of our decision making for treatment as well. And there's some variation there from surgeon to surgeon as to what people think and recommend. So I'll just kind of leave that at that.
Great. Got a couple questions about the AUS here. So next question is, if I've already had a sling surgery and found it to not be effective in treating my UI, can I then go back and have an AUS later?
Absolutely. Absolutely. So the sling tends to go a little bit lower down on the urethra. So to go in and put an artificial sling in somebody who has had a sling who, didn't get sufficient benefit from that, very straightforward procedure to do. You don't really, need to remove the sling and try and get, the sling out of there or anything. You don't have to do a big surgery like that. You basically can go down and find the urethra and just right above where that sling is, put in a sphincter in the normal way that you would otherwise do it.
All right. And the next question on the AUS is, this person says they have a penile implant already, and they're wondering how a AUS would be able to fit in the scrotum with that device already in there.
That's a great question. So the pump for the penile implant tends to be in the middle of the scrotum, right between the testicles. The pump for the artificial sphincter we put under the skin on the side of the scrotum. So it tends to be in a different area. It's also much smaller than the pump for the penile implant. The pump for the artificial sphincter is about the size of the tip of your index finger. It's pretty small. So patients who have both those devices in tend to not really notice any issue or trouble in terms of finding one versus the other and functioning.
Next question here. This person says they're scheduled for a scope procedure on their urethra soon, and they were wondering if that'll help detect the reason for their incontinence.
Yes. So the scope procedure is a standard part of the workup and evaluation that many surgeons do for patients that have incontinence. And especially if you're considering going in and doing a sling or an artificial sphincter procedure, you need to make sure that the urethra is healthy, that there's no scar tissue inside the urethra, and that there's no stones or tumors or other things in the bladder. So yeah, a scope procedure, you'll be able to go in, you'll be able to see the urethra, the bladder, you'll be able to look at the sphincter and see how well it closes. And then some things surgeons check as well sometimes is, they'll push down below to see how well the urethra moves, to kind of simulate what a putting in a sling would do. So scopes a lot of times are very helpful for us to figure out the anatomy and the factors that may relate to incontinence, but also the important ones we need to know if we're thinking about doing surgery to help it.
Certainly. Alrighty, next question here. This person says they had a radical prostatectomy and then radiation, and they're wondering if there's a way to find out if their sphincter is damaged or stiff. I guess they're trying to see if the sling would not work as well as the cuff, if that's the case.
That's a very good question. That's one that the jury really still is out on. There's some folks that do a lot of slings and sphincters, and they won't do slings in patients that have had radiation for that concern. They'll just exclusively do sphincter implants in patients who have had radiation. Some of the things that play into that, modern radiation is much more focused and targeted than it was decades ago. So radiation to the urethra and sphincter with contemporary prostate cancer treatment is probably less of an impact on the sphincter and things than it was way back when. That being said, the bladder scope or cystoscopy is one way that you can evaluate for that. Looking in there, you can push below to kind of see how well the urethral tissues move, to see if that sphincter muscle moves, or if it looks kind of stiffened and stuck open. But yeah, there's the jury's still out as to whether or not slings are as helpful in people that have had radiation as an artificial sphincter is.
Alrighty. Next question here. This person says they're 5 years post prostate surgery, and they're wondering if it's too late to consider an AUS.
Not at all. Not at all. If leakage is a problem, if it's impacting you and preventing you from doing what you want to do and feeling good about yourself, go talk to a urologist that does these procedures, and it shouldn't be an issue to be able to help you.
Alrighty. Time for a couple more. So next question here. This person says they're on 5 milligrams daily of Cialis for rehab following a prostatectomy and have what I believe is stress incontinence despite the pelvic floor exercises. Wondering if the Cialis could be contributing to this incontinence.
It's a good question. So tadalafil, the 5 milligrams of daily tadalafil is a strategy some folks will use after prostate surgery to help improve blood flow and possibly help stimulate regeneration and recovery of the nerves after prostate surgery. Based on how tadalafil works, it should not have any negative impact on incontinence. It should not, increase or worsen the severity of incontinence. If anything, it may actually relax the bladder a little bit as well and help hold the urine. If it's still kind of short term after prostate surgery and there's some leakage, I would say definitely make sure you're doing your Kegels. Keep that bladder hygiene in mind. Make sure you pee every 2 to 3 hours, and then watch out for those bladder irritants, sweeteners, flavorings, colorings, caffeine, and alcohol.
Alrighty, let's see. This will be our last question for the night. So if you have a question after this, please follow up accordingly after. I'll share the details in a second. But this next question, a small amount of leaking during the day, even after emptying the bladder. What recommendation here?
That's a very good question. Kind of hard to weigh in on without knowing more, unfortunately. But the simple strategies are really, for bladder hygiene. Make sure you're peeing every 2 to 3 hours. You're not holding it too long. Make sure you're not constipated. Take your time peeing. Make sure you empty out. Don't rush when you're in the bathroom. And then try drinking just milk or water for a few days if you're thirsty. Keep away from any of those bladder irritants that we've been talking about.
If you'd like to learn more about urinary incontinence, so on the Resource Center on menmd.com, you can visit this page to view instructional videos, guides, expert articles, and more. If you have a question that you did not have answered tonight and would like to speak with someone in person, you can also call MenMD at 857-233-5837 or log into our password-protected portal to schedule an appointment with one of our personal health assistants. If you're interested in purchasing any of the incontinence aids, such as the underwear or the clamps that we talked about tonight, or learning about how much they cost, you can do so by visiting the shop page on menmd.com, or again by calling our office at 857-233-5837. And finally, if you'd like to learn more about the surgical solutions, such as the sling or the artificial sphincter, you can do so by visiting fixincontinence.com.
If you found this video helpful and want to stay in the loop with our growing men's health community, be sure to subscribe to our channel and click the bell to be notified when new content is available. Your support makes it easier for other men like you to find these helpful resources. Thanks again for watching. We hope to see you again.